Okay. Good morning, everyone. Good evening. I know people will keep coming in through, but thanks, Mia, for really coming back again to teach. I think the neurology sessions last year were really the best. If I was to say the best lectures, unfortunately, I can't find. I think maybe Walter had recorded them, and I can't find them. And so maybe when you have some time, I'll have you just represent them again, because they were very, very high yield. I remember myself and Dr. Newsom thinking, wow, like we were all just like nodding and very engaged. So, thank you so much again and that was the feedback we got also from everyone else. So I think everyone who's attending today, people we know, Victor, Karibu, and we'll really appreciate this session. And hopefully this time I won't mess up the recording, if that's okay with you. But let's get started.
Okay, thank you. Thank you so much. I really enjoy doing this. So I'm very, very happy to be here. And for all those who have come.
Yeah, an introduction of yourself, because I didn't do that, sorry.
Okay.
We have some people.
Yeah, for all those who have come as well, thank you for taking off time to be here. I know that it takes a lot of dedication to take part in extra sessions like this. So the goal is to try to make this worth your time. So my name is Amir Monde. I am a neurology resident at the Mayo Clinic here in Phoenix. But originally from the South Coast region, Indiana, that's where my dad is originally from. But I did most of my training in Uganda prior to coming to the United States. So that's my background. And I'll be finishing up my residencies next year in June. And then moving over to do a stroke fellowship at Mass General Hospital in Boston. So I just got matched there, which is very exciting.
Congrats. That song was for you then. Wow.
Yeah, thank you. So the goal today is to go through the basal ganglia nuclei and how they correlate with some of the clinical conditions that we see. And so I'll jump right into it. There are 5 major nuclei that I always think about when I'm talking, when the word basal ganglia is mentioned. And that is
do you want to use the presenter mode so we don't have to see your left side?
Oh, presenter mode. Okay.
Like so present or something, or play.
So where do I go for that?
Like to the left, play.
To the
Keep
left.
into your left. Play.
Play.
Yeah, you were hovering above it. Play.
Like here?
Mm-hmm.
This is for the microphone. Oh, sorry.
Oh,
okay. All right. So yes, so there are 5 nuclei that I think about: the caudate nucleus, putamen, globus pallidus, subthalamic nucleus, and substantia nigra. My goal at the end of this talk is for you to be familiar with these nuclei and what they do exactly. This is a slice through the brain, an axial slide, kind of around the mid area of the brain. So, and just to orient you a little more, this will be the front of the brain. So the frontal lobe, this is the back of the brain, your occipital lobe. And then you have at the sides, you have your temporal lobe and your parietal lobes, which will hover around the sides here. You have your ventricles, the lateral ventricles right there. And just below the anterior horn of the lateral ventricle, that's where the caudate nuclei resides. The caudate nucleus is a weird nucleus in the sense that it makes this C-shaped curve starting from the head. This is what we typically refer to as the head of the caudate. And then it makes that C-shaped curves all the way to the tail of the caudate, which will be at the back here. But it's the head that we usually look at, say, on a CT scan. And then just below that, you have your putamen, which I sometimes like to refer to as a peripheral nuclei, so P for peripheral. And then on the inner aspect is the globus pallidus, where there's a globus pallidus externa and the globus pallidus interna. Okay. So these two, you have these two, and then that one there. And then we'll see the others on the next slides. But I also wanted to show you this big bulky structure in the midline abutting the ventricles. And this is called the thalamus. It has a key role in how these nuclei function, but it's not part of the basal ganglia nuclei. And then you then have this white strip, which is the internal capsule. All these fibers that are coming from the brain, from the cortical surface, from the homunculus, the motor nucleus, will pass through here to go down to the spinal cord. And this is how a section of the brain on autopsy would look like. Your caudate, your peripheral nuclear putamen, your globus pallidus and globus interna, the thalamus right there, and your internal capsule passing right there. We call this the anterior limb of the internal capsule. This, we call it the posterior limb of the internal capsule. And where the two meet is what we call the genu of the internal capsule. Now, there are a few things, a few combos here to keep in mind. The caudate plus the putamen, the peripheral one, collectively are usually referred to as the striatum. On the other hand, the putamen plus the globus pallidus, which are the two structures next to each other, are collectively referred to as the lenticular nucleus. The other components of the basal ganglia nucleus we haven't really talked about, but they are the subthalamic nucleus and the substantia nigra, and you'll see them shortly here. This is just an anatomy tip to help you remember the word striatum, which is the combo for caudate, just below the anterior horn, and the peripheral one, the putamen. There are these cellular bridges called striations that pass through the anterior limb of the internal capsule to connect the two, and they are the ones that give it the name striatum. Another tip here that helps me remember the lenticular nucleus is, personally, I look at it as it's in a shape of a lens, kind of a lens. But some people like to remember it as that the putamen, globus pallidus externa, globus pallidus interna take up, take up the shape of an ice cream cone. Now, the substantia nigra is a very, very, very important structure as well, but it's deeper. It's in the brainstem. This is a transection of the brainstem around the midbrain region. At the front, this is the back of the midbrain, the front of the midbrain. At the front is where you have the substantia nigra, which are these dark pigments which contain dopamine that, as you know, on autopsy, you can easily see it as well. These pigments, when you lose them, that's how you get Parkinson's disease. And in patients with Parkinson's disease, their midbrain looks pale rather than having this dark staining appearance. So it's really deeper compared to the ones that we've been talking about earlier. The subthalamic nucleus like the name suggests, is right below the thalamus on both sides. And it's also very, super important in the functioning of those nuclei that we already talked about. This is what most of you are accustomed to. You see this every day. It's called a CT scan of the brain. This is an axial view. We've taken an axial section through kind of that mid-level where you have the basal ganglia nuclei. And I'll give people a second to sort of fill in these, nuclei. Judith, you probably help me like last time again, or maybe I'll look at the chat.
Yeah. So please use the chat to say what A is, or you can just type all of them.
Just all of them. A is
A, B, C, D, E. And welcome, Dr. Newsom. As people type, it's been a while since we saw you.
It's a pleasure to be here. I'm afraid of typing because I may get it wrong.
I see.
So
yep.
A, several. Oh, can you see the chat?
I can see lots of correct A's there. Kevin, Jacqueline, Charles, Abdulatif. Awesome. B, yes, Charles. Yes, Kevin. Looks good. Looks good. Yep. C would be your globus pallidus, yes. All right, okay. So, yeah, E is thalamus, perfect, Jacqueline, perfect, Kabisa. And then D is your internal capsule. I just threw it in there to confuse, just to make sure that you don't forget that when you look at it on a CT scan. So the next time you pick a CT scan and look at that section, when you come to that section, you should be able to identify those structures pretty easily. They are very, very easy to identify, especially the caudate. It's usually that bulky nucleus just below the anterior horn. And the internal capsule, the thalamus, they are all very, very easy to make out on a CT, okay? And also, most of you are accustomed to looking at an image like this. This is a hyper dense lesion within the thalamus. So this would be blood. This is what you see in a hypertension related intracranial hemorrhage. And in this case, you're also seeing some extension into the ventricles. So yeah, this should be easy to pick out. And so when you're writing in your notes, you would say that this is intracranial hemorrhage involving the thalamus plus and maybe pushing away the internal capsule, or maybe pushing, or maybe extending into the internal capsule, hard really to say. So that would be good for you. So those are the nucleus. Switching gears to the functions of these nucleus. So what do they really do? They do a lot of things, but most importantly, are these four functions here. One is, so there are all these circuits that we're going to look at that connect the higher centers of the brain, or your homunculus and the motor strip, with the nuclei, and they all interact very closely to bring about these functions. One is motor planning and execution. So your frontal lobe will plan and say, I want to go and get a cup of coffee or get a cup of water, and then you have all those connections passing through the basal ganglia to then lead to the execution of the movement. And then saccades are the fast eye movements. If say something happened and I wanted to look very fast to my left or very fast to my right, that execution of movements is heavily reliant on the caudate nucleus. The interaction between the frontal eye fields in the forebrain and the caudate nucleus is what you need for the saccades. And then executive behavior and social behavior, these, or sometimes we which are part of the cognitive functions. This is what, for example, will stop you from going to pee on the street or going to steal things at the shop, or making sure you don't do weird stuff in front of people. That executive behavior and making sure that you're social, how you interact with people. That's all also crucially coordinated by that circuitry that interacts between the higher centers of the frontal lobe and the basal ganglia. And then motivation, which is limbic system, temporal lobe, also goes in through the basal ganglia as well. That motivation, that drive that made you come to this lecture today, rather than go to do something else, is also critically controlled by those two, by these structures. A quick look at the blood supply. Now, this is your middle cerebral artery coming off of the internal cerebral artery. And as the middle cerebral artery goes peripherally to supply the frontal lobe, the temporal lobe, the parietal lobe, it gives off these branches here, which we call the lenticulostriate branches. Again, you can see that there's the word lentiform in there. You can see that there's the word striatum in there. So the lenticulostriate arteries are basically the ones that supply the basal ganglia. And they're very easy to knock off because they come off the MCA, the middle cerebral artery, at a sharp angle, a 90-degree angle. Any elevations in blood pressure here, there is no tapering off. So when you look at the end here, there's this tapering off that allows the pressures to gradually come down. But right here, there's really no tapering off. And so when somebody's blood pressure spikes to 220, over 120, 180 over 90, these guys take a hit. And so you start to form those Charcot-Bouchard aneurysms that I'm sure some of you have probably read about. And it's those that then bleed and give you the structure, the bleedings that, like a bleed like this one is basically from a Charcot-Bouchard aneurysm from high blood pressure that had burst out. Same thing happens with ischemic stroke as well. These get clogged off from high cholesterol and things like that, and then you have an ischemic stroke in that region. So very, very crucial there. Now the circuitry, so switching gears to the circuitry here. Try to pay attention to the next 3 slides because they say it all here. So starting with this critical interaction between the globus pallidus interna and the thalamus. Remember, we said the thalamus was not part of the basal ganglia, but it has a very fundamental role in the way the basal ganglia nuclei work. The thalamus is always activating the cortex. Green is for enhancement or activation. That's its only job. That's all it does. So that means that we would all the time be moving, parts of our body would be moving, and we'll have no control. But then you have the globus pallidus. The way we are formed, where we were made, is that the globus pallidus interna then is always putting brakes on the thalamus and telling it to calm down. We don't need to move right now. So chill, relax. So the GPI will always do red onto the thalamus, always creates that tonic inhibition of the thalamus. And this connection is a very, very critical connection. We call it the pallidothalamic tract. That pallidothalamic connection between those two is critical for movement. So therefore, that means that if the globus pallidus is hyper-excited, if you excite the GPI will work extra, and then it will inhibit the thalamus even more. So the end result is no movement. But if you don't excite the thalamus, or if you reduce the activity of the thalamus, or the GPI, if you inhibit the GPI, then the GPI won't do its normal tonic inhibition of the thalamus, in which case the thalamus will be free to act and do its green activity, and you end up with movement. So that's how we decide. That's how I decide that I want to move this arm or not, by either increasing the tonic inhibition of the GPI and the thalamus, hence no movement, or decreasing that tonic inhibition of the GPI on the thalamus, hence movement. So very, very crucial there. And then the cortex is always exciting the basal ganglia nuclei, and typically it is the peripheral one, the putamen, that the cortex will work with. It's always an excitatory activity coming down from your frontal lobe telling you, oh, don't pee there, or coming down from your homunculus telling you, let's go and get a cup of coffee. The information will settle on the putamen first. Another critical or fundamental connection is the one between the subthalamic nucleus. Remember, we said subthalamic is right below the thalamus, and the GPI. Now, the subthalamic nucleus will always does two things. For it can do red or green. It can excite the GPI, and when it excites the GPI, okay, it is essentially stepping on the brake of movement, okay? Because once you hyper-excite the GPI, there's going to be no movement. The thalamus will be inhibited. So the subthalamic nucleus steps on the brakes of movement. You won't move if it's exciting on the GPI. And therefore, you know, when you have a lesion of the subthalamic nucleus, okay, instead of stepping on the brakes of movement, you have more movement, because you are removing that hyper-excitation of the GPI. You're taking it off, and hence the GPI won't inhibit the thalamus. And then what you end up with is something that some of you might have already heard of. It's called hemibalismus, which is this wide swing, high amplitude movements of one limb, uncontrolled, involuntary. So it's happening, you know, because somebody probably has a stroke or a lesion of the subthalamic nucleus. Now, what you have in your first aid is what we call the direct pathway or the indirect pathway, or what you would have learned in anatomy would be the direct pathway and in the indirect pathway. The direct pathway starts off from the cortex to the putamen. You have that excitatory activity. And then the putamen will create this, will then inhibit the GPI. Okay. And then when you inhibit the GPI, it means that the GPI will reduce that tonic inhibition. It won't be inhibiting the thalamus as much as it usually does. So you interrupt that tonic inhibition, and the end goal is movement. So that's what happens when you want to move.
Jacqueline has a question.
Yeah, sorry.
Jacqueline, do you wanna type your question? And Karibu also. I think you should be able to talk, Jacqueline, if you wanna ask.
Yes. I wanted a clarification about the subthalamus. Like Doc has said the subthalamus will like it steps on the brake, which is the globus pallidus internus. So does it inhibit or it activates?
Okay, so
yeah.
So you know, so this is an inhibitory. What do you mean by inhibit or activate? Inhibit.
Okay. Okay. You've already said the globus pallidus internus is like regulatory to thalamus, like it inhibits, being the thalamus is a relay center, so it inhibits the excitations of the thalamus. But now I think I got lost somewhere about the subthalamus. Does it activates the GPI or
So it activates the GPI.
Okay, so that means there will be a lot of inhibition on the thalamic functions.
That means that there will be inhibition. There will be a lot of inhibition of the thalamic function. Correct.
Okay, thank
And
you.
that means that there will be no movement.
Mhm.
And that's
So
why,
when we don't have the movement, that is the condition we get.
no. That's the normal. A normal functioning subthalamic nucleus will lead to no movement.
Okay.
Yeah?
Yeah.
Yeah?
So, okay. So for when we have an injury to the subthalamic nucleus, we'll have the GPI.
Excess unwanted movement.
Okay. Thank you so much.
Karibu.
Okay.
So that excess unwanted movement is referred to as hemibalismus. Okay. Yeah, good to clarify there. Yeah, so then this is the direct pathway. The direct pathway does not involve the subthalamic nucleus. It's very easy. It just involves these guys here, cortex to peripheral to GPI, but inhibiting the GPI. And anytime you inhibit the GPI, it means that you will have a reduction of that inhibitory activity of the thalamus, and then the thalamus or the relay center will then be able to activate and lead to movement. So the direct pathway is always leading to movement. And that movement, once the information comes back from the thalamus to the cortex, will be coordinated by or executed by the corticospinal tract that passes through that internal capsule that we looked at earlier.
Amir, someone wants you to repeat the direct pathway. I'm sorry.
Oh. Okay, so
the direct pathway.
Yes. Okay, so the direct pathway, remember we said the cortex is always exciting the putamen. And then in this case, the putamen then inhibits for the direct pathway. For the direct pathway, the putamen will inhibit the GPI. Okay? And once you inhibit the GPI, it means that you lessen or you interrupt that tonic inhibition of the thalamus. You bring it down. And when you bring it down, it means that the thalamus is now free to move because it doesn't have that brake that is usually there from the GPI. So then you allow the thalamus to have this excitatory activity on the motor centers of the cortex, which in this case is the supplementary motor area, or even the homunculus itself. So then you end up with movement. You're able to stand up and walk and go and do whatever you want to do through the execution of the corticospinal tract. So direct pathway movement doesn't involve the subthalamic nucleus at all. But the indirect pathway is what we're looking at next. You have that excitatory movement activity from the cortex to the putamen. And in this case, instead of the putamen going all the way to the GPI, the putamen is going to the GPE. Now, one thing to note is that because this movement, this initial input, initial part of the circuit is the same for both the direct and the indirect pathway, the difference will always be in the receptors that are receiving this information. Where is this information going to? Is it going to the D1 or the dopamine 1 receptors, or the D2, the dopamine 2 receptors for so D2 is for indirect and D1 is for direct. And that's what you have in your first aid as well. So the D2, if it's activated, it goes to GPE instead of GPI. And GPE will always inhibit the subthalamic nucleus. It's that red connection. And when you inhibit the subthalamic nucleus, okay, you are removing that tonic inhibition So there's lots of double negatives here. You're inhibiting the subthalamic nucleus, and in that sense, you are actually decreasing that inhibitory output that the subthalamic nucleus usually has on the GPI. And in that case, the GPI is freer to move. It's freer, it's being allowed to continue to do that inhibitory action that it has on the thalamus. So it's the opposite of what was happening in the direct pathway. So then you have increased tonic inhibition of the thalamus rather than the decreased tonic inhibition that we saw previously. And what happens there then is that the thalamus will not move, the relay center will not continue to do that excitatory movement that it has on the supplementary area. So the end result is less movement. So indirect pathway involves the subthalamic nucleus and does not lead to movement. It leads to inhibition of unwanted movements or competing motor acts. Say if I'm walking to the cafeteria, I need my arms and legs, everything to be moving in the same direction. I do not want the other leg to be moving in the opposite direction while I'm trying to go the other way. So that's the essence of the indirect pathway there. This is the picture that I took from the first aid book, just for you guys to look at what is probably more familiar to you. And it's the same thing. You have that green input to the periphery. It will act on either D1 or D2. If it's D1, then it's the direct pathway that is stimulated, which is peripheral straight to GPI, less inhibition of the thalamus, and then movement. If it's D2 that is activated, then you have D2 to GPE rather than GPI, GPE to the subthalamic nucleus, less inhibition of the GPI, or if you want to look at it the other way, stimulatory movement of the GPI, hence the GPI is stimulated and tonically inhibiting the thalamus. And when it tonically inhibits the thalamus, there's no movement. Again, the CST, or the corticospinal tract, all the way to the spinal cord and the limbs is what executes whatever these guys decide on. As you will see, there's one nucleus again that we haven't talked about, which is the one down there, the substantia nigra. For it, it's unique in the sense that it has diffuse stimulation of all the nuclei, or most of the nuclei. It works on everybody, and it uses dopamine. And those are the dopamine pigments that I showed you in the midbrain. So the substantia nigra pars compacta has those compact granules of dopamine that all these systems require to use. For example, the dopamine D1, D2 receptors of the putamen will require dopamine for that activity to function, and that's coming from those compact dark granules of the substantia nigra. And therefore, in patients with Parkinson's disease, when they don't have that dopamine input, everything that we've been talking about will be affected, whether it's the direct or indirect pathway. Okay. Okay, so a quick look at a few clinical correlates here. We've already alluded to the fact that Parkinson's disease is heavily involved in basal ganglia movement, and then again, to remind you guys a little bit about the functions. Right there, okay. So a patient with Parkinson's disease, if you assess them properly, they will not only have the motor deficits. So typically we look at Parkinson's disease as a disease with motor and extramotor clinical features. Patients with Parkinson's disease will have cognitive features, memory features. They will have issues with their thinking. They'll have issues with their motivation. They'll have issues with eye movement, on top of the motor features that we are typically accustomed to, which are the rigidity and the tremor. And that's because of that circuitry. The same thing happens with Huntington's disease. Just as a quick question, a quick pause, does anyone know can anyone type the trinucleotide repeat? What the trinucleotide repeat disorder, or genetic, which of the trinucleotide repeats are associated with, CAG, Doreen, thank you. So the Huntington disease is one disease that you guys need to be familiar with, because I think it's high yield if you are planning to do like step 1. And patients with Huntington disease in the clinical STEM will typically have they'll give you all these features, because for them, what is happening is that the caudate is usually what is affected in Huntington's disease. So the CT scan that you see here would be for a patient with Huntington. As you can see, there's really you cannot make out the caudate nucleus there. There's nothing to see. And the anterior horn of the ventricle has enlarged, so there's a little bit of ventriculomegaly to cover up that space that is missing. Other sample diseases that affect the basal ganglia, this would be a stroke. So if you look at the CT scan of a patient, and you can make out the caudate on the other side, you can make out the lentiform nucleus, the internal capsule, you can make it out there. But on this side, you really cannot make it out, because this is a very, very early stroke. So you see on the opposite side, you really cannot make out any of the structures. There's that blurring of the margins on this side. Okay, and also towards the end here, you see the gray-white differentiation is also not very clear. So we do see that. This is your Huntington's disease that I just spoke about. You really cannot make out the caudate, especially on this side. The other side, you maybe can, and obviously there can be some asymmetry in the hypertrophy of the nucleus there. And then for a patient with Parkinson's disease, that diffuse, involvement or diffuse delivery, for lack of a better word, of dopamine to all the basal ganglia nucleus will be inhibited. So you have this trap, which is a mnemonic that I use, and I'm sure most of you use, for Parkinson's disease features. That's a tremor, rigidity, there's no movement, akinesia, meaning, or bradykinesia, there's little to no movement, and then P is for postural instability. A patient of Parkinson's disease, when you do their autopsy and you cut the brain at the brainstem at the level of the substantia nigra pars compacta, you will see that instead of these beautiful compact granules of dopamine that are dark staining, it is really nothing. You're seeing just pale staining there. And oftentimes it's asymmetric. In this case, it is symmetric. So you might wonder whether this patient maybe had something else other than Parkinson's disease, something like multiple system atrophy, which is a cousin in a way of Parkinson's disease, and also kind of does the same thing, and it's more symmetric. Substantia nigra pars compacta right there. And then when you have too much dopamine, too much dopamine again leads to dyskinesias. And one situation where we see dyskinesias is in patients who are treated with first generation antipsychotics. You have those oral facial dyskinesias as a side effect of, say, chlorpromazine or haloperidol. And that's from that substantia nigra to GPI putamen involvement. This is a patient with a left basal ganglia stroke. involving mostly the, most of the things here. You can see there's a little bit of the internal capsule, there's a little bit of the lentiform nucleus, and this patient had hemidystonia. So dystonia on the opposite side. This is the left basal ganglia stroke. They were having hemidystonia on the right side. Dystonia meaning excessive contraction of both your antagonist and protagonist muscles. So then you end up with either a stiff limb or a twisted limb that is really not moving. Okay, that is it. Time for some review questions here. Again, we can type in the chat. So we'll say that hemibolismus on the left side is usually due to a vascular accident affecting the right. So we're waiting for answers here. I see quite a bit of A there. Abdul Latif, Jacqueline, Victor. I see some B's from Victor, Kevin. Yeah, so it would be, so the left side of the body, sorry, I should have been more specific there, not the left side of the brain. Hemibolismus, left side of the body, is usually would be from a right subthalamic nucleus, okay? It has to be crossed. We are cross-wired. Next question. This is a picture of the brain of a patient with Huntington's disease. Microscopically, you would see what? Okay. B, yep, B. So the caudate, the caudate is closely related to the putamen, like we saw. So it's part of that striatum, that striatum. But mostly it's usually the caudate that is affected. And obviously if the caudate is affected, then the putamen won't have any input or anyone to talk to. So it will also appear diseased in the brain of a Huntington's disease patient. So that's the autopsy of a Huntington's disease patient. A patient with a resting tremor in the right hand, okay, is killed in a traffic accident and is autopsied. The neuropathology report states that there is a loss of cells in the Yep. Good job, everyone. Priscilla, Kevin, Victor. Yep. Left substantia nigra. That is true. Again, they're having tremor in the right hand, that resting tremor of Parkinson's disease. They're having bradykinesia on that right side. It's because the substantia nigra pars compacta on the left side of the brain doesn't have as much dopamine. It's not supplying as much dopamine as it should. Okay, good job. The prominent caudate and putamen seen in this axial MRI section are separated by Kevin. Yep. Good job, everyone. Remember we said anterior limb of the internal capsule, genu of the internal capsule, posterior limb of the internal capsule, and that's where all your corticospinal fibers pass. Good job. Name the stroke syndrome. Symptoms. What symptoms would this patient have? What would be the etiology and what would be the affected artery? You can answer whichever part you want. You don't have to type everything. There's a lot to type, but just if you get one of these correct, it means you most likely get all the others correct as well. right lenticulostriate artery is fantastic. Duncan, Leon, yep. And the stroke syndrome, anyone? I didn't mention it in the talk anywhere, but it's a lacuna syndrome, pure motor syndrome. Yeah, I give you that, Irene. But it's the name is lacuna syndrome. A lacuna stroke is any stroke that is less than, according to the latest guidelines, less than 1.5 centimeters on measurement, either on CT or MR. And so yeah, it's a small stroke. In this case, it's involving the lentiform nucleus there. So you'll have all kinds of issues with movement on the opposite side of the brain, of the body. What does the pallidothalamic tract mean, and what structures do these tracts cross? That's your, yeah, a bit of typing there, but that's your globus pallidus and the thalamus pallidothalamic tract, and it's the critical, it's that critical one that is needed for both the direct and the indirect pathways. All right, there's a few other questions here that you can, always review, but you need to know the structures. So we've basically gone through the structures of of all the basal ganglia nuclei, the structure of the striatum, structures of the lentiform nucleus. We have gone through, the area where the caudate and putamen come together. That's just those striations. And we know the basal ganglia structure, which exerts tonic inhibition of the thalamus, that's your GPI. We know the structure that increases the tonic inhibition, that is either steps on the brake, that's your subthalamic nucleus. The subthalamic nucleus controls the GPI in many ways, either by lifting the brake or stepping on the brake. And dopamine will walk through either D1 or D2 as part of the direct or the indirect pathways. And that's the image in your first aid. Just as a by the way of a clinical correlate as well, sometimes patients who have Parkinson's disease that is refractory to treatment, we do what is called deep brain stimulation of the thalamus, one of the nuclei of the thalamus, the ventral intermediate nucleus of the thalamus, I believe. And that helps to treat refractory PD, but also it's the V and VL, so it helps to treat refractory PD. I don't think you need to know this, but I just threw it in there as a by the way. All right, tumefika mwisho. Asanteni sana kwa kusikiliza. That's it.
Awesome. Dr. Newsom, don't tell us your Swahili words that you've been learning, but are there any questions? And so first of all, we recorded this, so I strongly encourage for people to go back and watch. This is very, 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 very high yield, and just the presentation, like I said, Amir here gives, I'm not just saying that so he comes back, but just very, very good way to just wrap up a very difficult challenge, question, neurology. So I see, thanks a lot. Okay, wish you would do another review of spinal tracts. I think we should just have, because Walter lost my recordings, we should have, maybe when you have some time, you come back and do the previous lectures that you did, the ones for stroke. They were very, very good. But there's a request to do one on another review of spinal, yeah. Okay. Awesome. Then Walter, any words, and then Denise will end for us.
Thank you so much for giving me the opportunity, and thank you, Dr. Mbonde. I hope I'm saying your name correct.
Perfectly.
Yep. So, I mean, this is awesome. We have been looking for someone to help us with neurology. Sometimes I try to step in. I'm not that good. So I think it's good I lost some of the recordings so that you can, you know, step in and help us. Thank you, Judy, for what you do. You have been keeping this forum running. And thank you, and Dr. Newsom too. And thank you everybody for joining today. I don't have much to say. I'm training to be a psychiatrist, so I look for time also to have a session once in a while. Thank you so much.
Awesome.
And,
Dr. Newsom, any last words?
Last words is that in the US, this weekend is something that we call Memorial Day and or Memorial Day weekend. And it's meant to remember, you know, people that have sacrificed so much for our freedoms. And as we start up this sessions again, I know you are in Kenya and all over the world, but I'm going to use this weekend to remember, you know, our times together and really what started this. And as we start seeing how, you know, this virus and COVID-19 is kind of going down, we see the curves are going down, mostly all over the world. I am still, you know, some people are, you know, we remember most of the sad things that happened over the last year, but I also remember that if it hadn't been for COVID-19, then we wouldn't have had this forum. I wouldn't have been able to meet all of you. I wouldn't have learned so much neurology in my whole life. My gosh, all the neurology lectures we've had. But I'm going to use this weekend really in just to remember all the things that, you know, we've gone through over the years, the good ones and the not so good ones, but mostly for the friendships that we have formed and the lasting bonds that will remain. So you guys have a great next week, this weekend, and we'll see you all soon.
Okay, so I will thank you so much for a great message. Thank you, Amir, and I probably will give a lecture which really we made with Dr. Newsom. Rather, she made it, but I'll give a lecture on PE next weekend. Okay.
Fantastic. Thank you, everyone. Thank you, Dr. Newsom. All right.
Bye.